Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai here in New York City. Thank you for joining me for this 335th episode of Pediheart. I hope everybody enjoyed last week's episode on cardiovascular surgery and specifically hematochezia seen in patients who've had a stage 1 palliation in the newborn period. For those of you interested in the postoperative course of patients following hypoplastic left heart syndrome surgery, I'd certainly recommend you take a listen to last week's episode 334. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, we move on to the world of heart failure and transplantation. The title of the work we'll be reviewing is Long-Term Survival in Children Following Heart Transplantation. The first author of this work is Emily Hayes, and the senior author, Gerard Boyle. Dr. Hayes comes to us from Nationwide Children's Hospital in Columbus, Ohio. Dr. Boyle from Cleveland Clinic Children's Hospital in Cleveland, Ohio. When we're done reviewing the paper, Dr. Hayes has kindly agreed to speak with us about it. Therefore, let's move straight on to our article and then a conversation with the work's first author. This week's work begins with some general comments about pediatric heart transplantation, reviewing how the first such transplant was nearly 58 years ago and how short-term outcomes from this procedure have markedly improved over the decades, which the authors review is largely due to improvements in diagnosis and treatment of graft dysfunction, early rejection, and infections. And they review how there is roughly 400 to 500 pediatric heart transplantations performed annually in North America, with 1-year survival exceeding 90%. However, the authors contrast this to long-term survival, which can be negatively affected by coronary artery vasculopathy, late graft failure, rejection, infections, and other issues related to chronic immunosuppression. The authors review how a recent ISHLT study showed median survival after infancy transplantation to be 24.5 years, but they contrast this with those transplanted during adolescence, where median survival is closer to 14 years, and they review how the older the patient is during childhood at the time of transplant, prior studies have suggested worse outcomes. The authors also make the important point that although early 1-year survival rates have markedly improved and continue to do so, there has been little change in long-term outcomes for the pediatric heart transplant patient. With this as a background, the authors suggest that there is a paucity of data on long-term outcomes of children undergoing heart transplantation, and suggest that it would be important to better understand factors associated with better or worse long-term transplant outcomes, with the goal that this might improve pre-transplantation care, candidate counseling, and management of these patients after transplantation. This was a Pediatric Heart Transplant Society, or PHTS, retrospective study, and those of you who are regular listeners know that we have reviewed this database and prior studies based upon it in this podcast before. For this study, the database was queried for all patients less than or equal to 10 years of age at the time of transplant, who also survived to 3 years, and who received their first heart transplant between January 1st, 1993 and December 31st, 2010. The authors analyzed those who survived to 3 years and also the subset who did to more than or equal to 10 years post-transplant, and they reviewed the many different factors or variables that they analyzed, and the list is positively dizzying, and I would recommend listeners take a look to section 2.3 of this work for the details. For this work, the primary outcome was survival following heart transplant, and secondary outcomes included freedom from rejection, infection, coronary artery vasculopathy, and post-transplant lymphoproliferative disease, or PTLD. And on to the results. 1,610 patients less than or equal to 10 years at the time of transplant survived to 3 years post-transplant, and of these, 1,170 survived to 10 years post-transplant. Looking at the 1,610 patients who survived to 3 years after transplant, 45% were alive and being followed, 28% were transferred to other institutions, 17% died, and 10% were retransplanted. Of the 1,170 who made it 10 years or more, 61% are still alive and are being followed, 24% were transferred to other institutions, 8% died, and 6% were retransplanted. There are many data in this work, and rather than confuse you with presenting too many, I'm going to, of course, recommend that you read this relatively short paper, but the important question for this week in this work was clearly what factors were associated with worse or better outcomes. Well, as has been shown in previous works, patients less than 1 year of age at the time of transplant have improved survival compared to all the other groups. In a multivariable analysis, risk factors for graft loss after 3 years post-transplant were malignancy, rejection, cardiac allograft vasculopathy, older age, presence of congenital heart disease, female sex, and black race. Of the patients less than or equal to 10 years of age with survival to 3 years post-transplant, 82% survived to 10 years and 71% to 15 years. And for those who survived to 10 years, 85.5% survived to 15 years and 75% to 20 years post-transplant. Again, if you made it 10 years out of transplant, you had a 75% chance of making it to 20 years. Table 5 displays the factors associated with graft loss in patients less than or equal to 10 years at the time of transplant, who had conditional survival 10 years post-transplant in a multivariable model, and factors associated with the loss of graft were recent rejection, diagnosis of coronary vasculopathy prior to 10 years after transplant, number of rejections with hemodynamic compromise, and at lower hazard ratios, the age of transplant, older being worse, and average steroid use, more being worse. Figure 4 on page 8 shows graft loss beyond 10 years based on time of transplant and shows that being a black female was a substantial risk factor with the worst long-term outcomes. If a patient lived to 3 years after transplant, there was 86% freedom from malignancy at 15 years and 81% at 20 years post-transplant. And there were 56 such malignancies after 10 years in the cohort group amongst those who survived 10 years, and the majority were PTLD lymphoma. Amongst those who made it 3 years out from transplant, at 15 years, 68% were free of coronary vasculopathy, and at 20 years the number fell to 52%. So again, amongst long-term survivors, about 50% at 20 years had coronary vasculopathy. In their discussion, the authors state that in this analysis of pediatric heart transplant recipients, they demonstrated the long-term effectiveness of pediatric heart transplant. To quote them, additionally, consistent with prior literature, we found improved long-term survival in infants compared to other groups. We also identified risk factors for graft loss, including female sex, black race, malignancy, rejection, and coronary vasculopathy. The authors re-emphasize that amongst those transplant recipients who made it 10 years, 15 and 20-year survival was good at 86% and 75% respectively. They mention how the 3 and 10-year survival was similar between cardiomyopathy and congenital heart patients. They mention also how those who were transplanted at earlier stages of single ventricle palliation than Fontan seemed to do better, and they mention the comorbidities of Fontan patients like renal and liver disease, as well as aortopulmonary collaterals and PLE, not to mention greater surgical complexity. And they make the case that when single ventricles are being considered for Fontan, it might be wise in some cases to consider if transplantation would be a better solution. We all remember, of course, Dr. Mark Gewillig telling us in a prior episode of this podcast, don't make bad Fontans. The authors reemphasize the finding that younger transplant patients generally had improved survival and suggest that it is due to two important factors of adolescence, specifically noncompliance, as well as differences in the immune system of older versus younger patients. They review their important finding that black race and female sex were both associated with increased risk of mortality in those who survived to 3 years post-transplant, and mention that female recipients in general were older and more likely to have cardiomyopathy as their underlying disorder. Black patients were older and were more likely to be listed priority status and more likely to be on inotropes at the time of a transplant, and they had shorter donor ischemic times. And these characteristics in general are thought to be associated with improved outcomes. But when comparing survival, black females still had worse outcomes in comparison to non-black males who had the best survival outcomes. The authors wonder if there are biological factors that may account for this, but also speak of social factors, including adverse childhood experiences and how the presence of these is associated with worse outcomes of health, and they are more common in females and black patients. The authors also remind that one of the more important findings is that there continues to be an ongoing risk for both late rejection and coronary artery disease over time. They speak of limitations of a retrospective database where accuracy of the data cannot be formally confirmed, and how it misses data once patients are transferred to adult programs, and centers do this at different ages, meaning that because of this very significant variability, some of the data on long-term follow-up may only reflect a few centers who continue to follow these patients long-term and do not transfer to their adult programs either in their center or elsewhere. As is always the case in a retrospective database, the authors mention the inability to directly assess treatment effects. And so they conclude, heart transplantation remains an effective therapy in children with a growing number of long-term survivors. Coronary artery vasculopathy remains the leading cause of morbidity and mortality, with a low but persistent risk of infection, rejection, and malignancy. Furthermore, Black race and female sex are risk factors for graft loss, highlighting the need for further investigation to understand the social and biological causes of racial and sex disparities in pediatric transplant recipients, as well as the ongoing need for tailored immunosuppression and post-transplant surveillances based on patient risk factors to improve long-term outcomes. Well, this is certainly an interesting work, giving us all some insights into long-term outcomes of our pediatric heart transplant patients. Certainly one of the most important findings in the work is that female, non-white patients had the worst long-term outcomes, and I certainly think that this will be something we'll want to ask Dr. Hayes about. As someone who does a lot of catheterizations on these patients, I would love to learn more about the coronary vasculopathy seen and why the rate seems to be so high at long-term follow-up. In the interest of time, I think we should just move forward to our conversation with the work's first author, Dr. Emily Hayes. Emily Hayes is a graduate of the University of Louisville for medical school. Following this, she completed her residency at Le Bonaire Children's Hospital in Tennessee, followed by fellowship in general cardiology and heart failure and transplant at Nationwide Children's Hospital, Ohio State, where she is presently on the faculty as a heart failure and transplant expert. It is a pleasure to have her join us this week on the podcast. Welcome, Dr. Hayes, to Pediheart. I'm here now with Dr. Emily Hayes of Nationwide Children's Hospital. Dr. Hayes, thank you very much for joining us this week on Pediheart.
Thank you so much for having me. I'm excited to be here.
Really excited that you could join us this week. Congratulations to you and your many co-authors, and also, of course, to PHTS, a fountain of great information in your field. I'm wondering, Dr. Hayes, sometimes I'll ask authors if they could maybe share with us, as the author, what you think are the 3 or 4 most important observations or take-home points from the work that you've authored and that we're reviewing this week.
Yeah, of course. So I think for me, there are 3 important findings that we identified in our analysis. First, I think my biggest takeaway is that overall patients who receive a heart transplantation in childhood have good longer-term survival, with most surviving into an early adulthood. Mm-hmm. Second, Black race and female sex were both risk factors for graft loss, with Black females having the worst outcomes when comparing both race and sex combined. I think this is particularly interesting as Black patients and female patients were both more likely to have cardiomyopathy as the reason for transplant and have shorter donor ischemic times. And both of these are factors that we know have historically been associated with improved outcomes in transplant patients. Yeah. And then finally, cardiac allograft vasculopathy remains a problem in pediatric heart transplantation. And in our study, like many other studies, it was the leading cause of morbidity and mortality.
Well, thank you for that. That's great. I feel good because I've already recorded the summary of the paper, and I think I hit most of those points, and our questions are going to focus on those, so I'm happy to see that. Dr. Hayes, as you just said, coronary vasculopathy is something that continues to plague transplant recipients even 20 years out. In your work, I think 52% had evidence of coronary vasculopathy at 20 years. I'm wondering if you could, this might be a basic question for a transplant doctor, but most of the people who listen are not in that field. I'm wondering if you might be able to explain to the audience the causes of coronary vasculopathy in the transplant patient population, and I wondered if there were any innovations that may be coming to reduce this risk in the future.
It's a great question, and unfortunately, I do not have great answers. So, as you said, CAV is very problematic. It is diffuse concentric narrowing of the donor coronary arteries that ultimately develops in all transplanted hearts. And we don't fully understand the pathophysiology. We do think it's primarily immune-mediated. And we do know that patients are at increased risk with episodes of rejection. There are some non-immune factors that we have contributed to CAV development, particularly in adults, such as hyperlipidemia, hypertension, and endothelial damage from systemic infections. Not only is it hard to understand the pathophysiology of it, it's also hard to diagnose it, which is also a problem in managing these patients. And so really it's only able to be seen by coronary angiography. Some adult programs are using intravascular ultrasound and cardiac MRIs, but unfortunately that's not an option for all of our pediatric patients just based on their size.
Yeah.
And then there's no great treatment options for it either, unfortunately. So most patients, once they have more aggressive CAV, their only option is retransplant.
Right. I see.
So you asked about some of the innovations. We do use mTOR inhibitors, so sirolimus or everolimus, and those have been shown to decrease the frequency and severity of CAV. We also use low-dose aspirin and statin in patients. This has good data in the adult transplant population and equivocal data in our pediatric patients. So I think there are two big strategies that I foresee in the near future. The immune system is not well understood. And so as we learn more about the immune system, I think the development of newer immunosuppressant medications will be big for our field. There are some agents that are currently being studied in the adult world, and I expect those to filter down into the pediatric population.
I see.
I think another big innovation that I would like to see for our patients is more personalized medicine. And so again, in the adult world, we're starting to understand more of the genomic variation in the metabolism of immunosuppressants. And I think that will ultimately help us become more efficient and effective in our immunosuppression regimens for these patients.
I'm old enough to be from the era when patients used to get cyclosporin and a lot of steroids. And what I'm about to ask you is going to belie the fact that I am not a transplant doctor, although I play one on TV. And my question is, I was wondering when you were talking about immunosuppression, is it known that on the newer agents, the mTOR inhibitors like sirolimus, that the incidence of coronary vasculopathy is lower? Is that now the case in comparison to prior eras when people were mostly on cyclosporin and steroids?
It has been shown to decrease the frequency and severity of CAV in transplant patients. So each institution has their own immunosuppression regimen, and it's obviously patient-specific as well, but most centers are using lower doses of calcineurin inhibitors and adding on an mTOR inhibitor to kind of get both benefits.
Got it. Okay, excuse the low quality of that question, but I was just wondering. It makes sense, I guess. Well, Dr. Hayes, one of the most important findings, as you explained to us in my first question today, was that being female or black race was associated with worse outcomes, which was certainly not expected, particularly given what you just explained to us about the fact that by most criteria they would be considered to be the lowest risk category patients based on the fact that they were mostly cardiomyopathy patients. I'm wondering if you might be able to speak to us about both the possible biological as well as social reasons that might at least partially explain this. And I was also very interested, you used the term adverse childhood experiences in the discussion in your work, and I was wondering how this factors into this very important observation you've made through this large database.
Yeah, thank you. To me, I think this was the most concerning finding in our analysis, and to sound like a broken record, unfortunately, we don't have great causes for these disparities that we've identified. I personally believe it's multifactorial, and as you mentioned, it has biological and social causes that contribute. I think from a social perspective, there is systemic racism and implicit bias that remains a problem in our society and for our patients. The adverse childhood experiences are traumatic events that occur in childhood, such as experiencing abuse, witnessing violence in the home, substance abuse in the home, and instability due to parental divorce or an incarceration. And so we've shown that increasing adverse experiences, specifically 4 or more, are associated with poorer outcomes both at the time of the event and long-term into adulthood. And so it's been correlated with cancer, coronary artery disease, and diabetes and long-term diseases like that. The proposed mechanism for it is that it's a chronic activation of our stress response system, and this leads to a pro-inflammatory state. And so I think it's, we don't have great data, but I think from a pathophysiology standpoint, it makes sense that a pro-inflammatory state would be detrimental to a transplanted organ. And so PHTS doesn't capture this data in the database, so I think it's an interesting area. And I think for now, we should be screening our patients for ACEs, and those that kind of meet that 4 event threshold or more, we should follow more closely and potentially even treat more aggressively in the post-transplant period.
Yes, I guess, leading to your prior comments about personalized medicine. So maybe that's an area, a new area of personalized medicine. Well, for those in the audience, it's late in the afternoon, but still during the work hours, and Dr. Hayes was nice enough to give us time right in the middle of her busy afternoon. So I'm going to wrap it up with one last question. Being less than a year of age at the time of transplant has been associated with improved long-term graft survival, both in prior literature and nicely in your study as well. I'm wondering if you could review for the audience, what is the presumed explanation for this? And are there any ways that what we're observing in our youngest patients with reduced rejection, could we leverage some of that, what we know about that, to help our older patients?
Yeah, that's an excellent question. So I think for transplant, the holy grail for us is immune tolerance of the grafts, and I think infants are as close as we get to that. Again, we don't fully understand the immune system. We do know that infants have a relatively immature immune system, which improves their long-term graft survival and also allows for ABO incompatible transplantation. We do know they have fewer B and T cells compared to older children, which potentially helps with this immune tolerance. And I think this is a big area of focus in the research world, is 1, understanding the immune system as a whole, and 2, focusing on infants and what we can learn from them and leveraging that to help guide future treatment options for the rest of our patients.
Yeah. Well, all interesting and excellent points. Well, Dr. Hayes, again, I want to thank you very much for taking time from your schedule to speak with us this week on the podcast. And once again, I want to congratulate you and all of your co-authors from the PHTS. I know it's a very big effort for all the centers to enter their data over many, many years. And so I want to congratulate you and all your co-authors. And again, thank you so much.
Thank you for having me. I'm a big fan of the podcast.
Thank you very much. Well, I'm sure you share my delight at many of the answers that Dr. Hayes gave to us today. I found her comments about the various reasons that black females did worse at long-term following heart transplant to be of great interest, and there clearly is a lot to do to fix that. I also found her comments about the reasons that infants do better than older patients at transplant to be of great interest. Off-air, we spoke a bit about xenotransplantation, and she explained that it was her belief that once a few more such procedures have been performed in adults and the results formally presented and reviewed, this may be an option for our patients in the future, and this would be quite an extraordinary advance. Of course, at this time, this is still a bit of science fiction, and we certainly will be eagerly waiting for more information on that. But in the meantime, we must continue to innovate ways to improve our modulation of the immune system and surveillance of these patients. I'd once again like to thank Dr. Hayes for taking time this week to speak with us on Pediheart. To conclude this 335th episode of Pediheart Pediatric Cardiology Today, we reach back over 70 years to hear a wonderful golden age pairing of 2 amazing singers, the tenor Jan Pierce and baritone Leonard Warren, singing the famous duet Solemne in Quest'ora from La Forza del Destino. Both singers were superstars on the operatic stage in the 1940s and 50s. Pierce and Warren were both originally from New York City, and I've mentioned once previously on this podcast that Pierce was actually even a friend of my grandfather, Samuel Waldinger, who lived, like Pierce, on the Lower East Side of New York City in the early part of the 20th century. Sadly, Warren died on the stage of the Metropolitan Opera in 1960, during this very same opera, La Forza del Destino, and he died during the opera just after singing this very duet, then with the tenor Richard Tucker, when Warren said the words, "Morir tremenda cosa," which means to die, a monstrous thing, and sadly and tragically died immediately thereafter. Thank you for joining me for this 335th episode, and thanks once again to Dr. Hayes. I hope all have a good week ahead.
Stringo